Good evening to the esteemed members of my extended family. I, Dr. Archana Khare, welcome you all for the today's CME. Infertility issues in India have seen a rampant rise due to lifestyle modification. Everyone, please be seated. Good evening to the esteemed members of my extended family. I, Dr. Archana Khare, welcome you all for the today's CME. Infertility issue in India have seen a rampant rise due to lifestyle modification. May it be due to late marriage, obesity, junk food culture, smoking or alcoholism. The percentage of couples facing infertility have risen. Infertility affects the concerned couple emotionally and psychologically, and indirectly also affect the social well-being of the entire family. The WOW committee states that infertility is also a major factor responsible for rising cases of domestic violence against women. In a nutshell, infertility can be called a social problem, which has been made this topic of immense importance for modern OBGY. I feel it is not only our medical duty, but also a social duty as a responsible and empathetic member of the society to understand and help and tackle infertility issues. The journey of parenthood can be full of challenges, and for some couple, these challenges can start even after the moment when they consider planning a baby. Infertility often comes with a grief and loss. You have to let go the vision of how long the journey will be and learn to flow and become stronger through this process. Yes, to start infertility journey, we will be the hope for these couples. Let's start the CME with our great tradition of lamp lighting, to pray, to nurture and to believe that God is always there with us whenever we serve to the people. I request Dr. Sunita ma'am, Dr. Ganapule sir, Dr. Girish Kumthekar sir, Dr. Anjali Jamma ma'am, and all office bearer of the SOGS to come on the dais for the auspicious ceremony of the inauguration. Thank you everyone. I request Dr. Anjali Jamma ma'am please to share her presidential address.
Good evening, one and all. It gives me immense pleasure to welcome our esteemed speakers, teachers, seniors, and my dear friends. As June being an Infertility Awareness Month, we are here with a very interesting and important topics related to the infertility. Infertility issues are increasing day by day due to enormous varied reasons. According to WHO estimate, the overall prevalence of primary infertility is alarming in India. Motherhood, the ART of inclusion. To treat infertility, it is utmost important to know now the ART procedures, who can do, when, where can be done, and what are the rules. Our own lawyer, Dr. Girish Kumthekar sir, will enlighten us on ART bill. And the most neglected and undertreated part is male infertility, and still many people don't involve male partner in the treatment protocol, or they don't reach us, or we just refer them. So to discuss endocrinology of male infertility, we have a great orator, academician, Dr. Chaintanya Ganapule sir. Endoscopy plays an important role in treating infertility patients. Last but not least, the iconic personality with multiple dimensions, Dr. Sunita Tandulwadkar madam. One of the aspects of hers is a social responsiveness. विंदाच्या ओळी आठवल्या, देणाऱ्याने देत जावे, घेणाऱ्याने घेत जावे, घेता घेता एक दिवस देणाऱ्याचे हात घ्यावे. She had donated endoscopy unit to VMMC, her alma mater. Great humanitarian gesture. Her passion is endoscopy. She is a perfectionist endoscopy master and will elaborate on mastering the challenges in endoscopy. We are lucky to have such a stalwarts today. Thank you, faculties, and all of you. Thank you very much.
Thank you, ma'am. Let's start with today's CME. I request Dr. Shashikant Umbardhan sir to chair the session. Welcome, sir. Shashikant sir is young and dynamic infertility specialist of our town, always ready to help others, and also work for high-risk obstetric. Over to you, sir.
Thank you, Dr. Archana, for kind words. Now I would like to call upon stage our beloved teacher, Dr. Kumthekar sir. Sir don't need any introduction in our society, but in short, he is practicing in our in obstetrics since last 31 years. As a medical legal consultant, sir is practicing for almost 20 years, and as an infertility consultant since last 15 years. Sir is a partner in the state-of-art ART center in Solapur since last 15 years. Sir owns a 12-bedded maternity hospital in our city. He is a medical legal consultant for our society as well as Hospital Owner Association. Sir will now enlighten us on the new ART bill, what to do and where we are.
Good evening, everybody. At the outset, I thank you, Solapur Society, for giving this opportunity to open the topic, which is high and dry, not full of no graphics, nothing. Only words, which are indecipherable, which I will try to make as easy and understandable as possible for all of you. Let's discuss the timeline. Of late, you are all aware that Surrogacy Act and the Artificial Reproduction Technology Act have been introduced and implemented, have been notified. The rules have been formed, but still they have not been gazetted, so that they are not as such implemented into it letter and spirit. But the time is not, the day is not far away. They will soon be implemented. But let us try to understand. But the timeline is like this. 14 September 2020, the bill was introduced in Parliament. 19 March 2021, Standing Committee report was submitted. 1st December, it was passed by Parliament and subsequently by the Upper House. 18th December, it received assent by Honorable President, and 20th December, it was gazetted and published by authority, that is, Central Government Gazette, it published it. But still, the rules are yet to come, and that's why implementation is, rules have been formed. They were invited for some suggestions. Now the suggestion time is over, so they will be soon formulated and it will be gazetted, and then the law will be implemented. So this is the latest letter dated 13th May, which states that still directed to say the assisted reproductive and surrogacy are yet to be notified for the purposes of ART Technology Act and the Surrogacy Act. This has been clarified by the central government on 13th May. So once they are notified, they will be implemented. So before that, let's be ready for the act, because many people, the young generation particularly, they want to jump into laparoscopy, either laparoscopy because of the glamorous personalities like Sunita, or infertility because of another glamorous personality like Chaitanya. So they are tempted to go into two fields rather than obstetrics and gynecology. Nothing to blame, not to blame them, but the things are like that. So let us try to understand the act as early as possible. So it's the Act for Regulation and Supervision of the Assisted Reproductive Technology Clinics and the Assisted Reproductive Technology Banks, Prevention of Misuse. Yeah, thank you. Safe and ethical practice of assisted reproductive technology services for addressing the issues of reproductive health where assisted reproductive technology is required for becoming a parent or for freezing gametes, embryos, embryonic tissues for further use due to infertility, disease, or social or medical concerns, and for regulation of supervision of research and development, and for matters connected therewith or incidental thereto. Typical legal language. This is the preamble of the Act. And he explains why this Act is coming into force. The thing is, when things go bad in the society, someone of the society comes up and says that it has to be regulated. Same thing happened with ultrasound and sex determination, all these things. And same thing happened with surrogacy. It was happening with artificial reproduction technologies, so the Act has to come to regulate the procedures. Let's understand the key features of the Act. The bill defines ART to include all techniques that seek to obtain a pregnancy by handling the sperm or the oocyte, immature egg cell, outside the human body and transferring the gamete or the embryo into the reproductive system of a woman. Examples of ART services include gamete, sperm or oocyte donation, in vitro fertilization, and gestational surrogacy. The child is not biologically related to surrogate mother. ART services will be provided through ART clinics, which offer ART-related treatments and procedures, and ART banks, which store and supply gametes. Things are very clear, nothing to explain in it. The regulation of ART clinics and banks. The bill provides that every ART clinic and bank must be registered under the National Registry of Banks and Clinics of India. The National Registry will be established under the bill and will act as a central database with details of all ART clinics and banks in the country. This is very important for research purpose also. State governments will appoint registration authorities for facilitating the registration process. Clinics and banks will be registered only if they adhere to certain standards, specialized manpower, physical infrastructure, and diagnostic facilities. The registration will be valid for 5 years and can be renewed for a further 5 years. Registration may be cancelled or suspended if the entity contravenes the provisions of the bill. Conditions for gamete donation and supply. Screening of gamete donors, collection and storage of semen, and provision of oocyte donor can only be done by a registered ART bank. So the middlemen are out of it. A bank can obtain semen from males between 21 to 55 years and oocytes from female between 23 and 35 years. These are very clear-cut guidelines. An oocyte donor should be an ever married woman having at least one alive child of her own, minimum 3 years of age. The woman can donate oocyte only once in her life, and not more than 7 oocytes can be retrieved from her. A bank cannot supply gamete or a single donor to more than one commissioning couple seeking services. The things guidelines are very clear. The guidelines say that you cannot take out more than 7 oocytes. Now here is the game. Improvised rules say that in certain circumstances, this retrieval can extend up to 15. So the law is a very tight, watertight compartment. But the derivations of the law or its interpretations or its flexibility is prescribed by the rules. So the rules say that in given circumstances, at the discretion, this can be extended to 15, is a retrieval of 15 oocytes. Conditions for offering ART services, these are the key features. ART procedure can only be carried out with the written informed consent of both the party seeking ART services as well as the donor. There is a list of at least 10 consent forms to be compiled by every ART center before undertaking ART procedure in any given patient. ART services, the parties seeking ART services will be required to provide insurance coverage in the favor of the oocyte donor for any loss, damage, or death of the donor. A clinic is prohibited from offering to provide a child a predetermined sex. The PCP comes here also. The bill also requires checking for genetic diseases before the embryo implantation. Now again, this law suggests that every embryo should be screened for genetic diseases. Again, the rules prescribe some exception to it, that if you are suspecting something, that means not every patient of ART should be for PGD or fragmentation and all these things, oocyte evaluation and all these things. So the rules are to be implemented along with, and the rules are the things which really govern the working of ART centers. Rights of a child born through ART. A child born through ART will be deemed to be a biological child of the commissioning couple and will be entitled to the rights and privileges available to a natural child of the commissioning couple. A donor will not have any parental right over the child. This has been explicitly, sorry for that. This has been explicitly, it is covered in Surrogacy Act also. One point I forgot to cover about insurance. A comprehensive insurance is to be provided to the donor and it should extend up to 1 year. The insurance should be provided for 1 year if anything happens to that donor. And a donor will not have any parental right over the child. So even if you are keeping the records and after 18 years of the child, ART child, and he comes seeking who are my natural parents, but still the custody and all legal rights cannot be transferred from the parents, biological donor and all these things. Only the commissioning couple will be the rightful parents of the child. Offenses and penalties, of course, every law comes with offenses and penalties. Offenses under the bill include abandoning or exploiting children born through ART, selling, purchasing, trading, or importing human embryos or gametes, using intermediates to obtain donors, exploiting commissioning couple, woman, or the gamete donor in any form, be it enticement, be it whatever, money, or it compensation of any form, and transferring the human embryo into a male or an animal. These offenses will be punishable with a fine between 5 and 10 lakh rupees for the first contravention. For subsequent contraventions, these offenses will be punishable with imprisonment for a term between 8 to 12 years and a fine between 10 to 20 lakh rupees. Any clinic or bank advertising or offering sex selection ART will be punishable with imprisonment between 5 and 10 years or fine between 10 lakhs and 25 lakhs or both. So the punishments are clear. See, so these are the key features. Why I have compiled them in a short form? Because I'm not going to tell you all the 36 sections which are into 16 pages of the Act. There's quite a complicated legal language, and or, 1, 2, 3, 4, 5, some explanation. We just can't decipher it in a common platform like this. So I've taken out the key features of the Act, and these are in a nutshell what the Act is going to be. Now let's go and see some definitions. Assisted reproductive technology with its grammatical variations and cognate expressions means all techniques that attempt to obtain a pregnancy by handling the sperm or the oocyte outside the human body and transferring the gamete or the embryo into the reproductive system of a woman. This is verbatim from the law. Woman means any woman above the age of 21 years who approaches an assisted reproductive technology clinic or ART bank for obtaining the authorized services of the clinic or bank. ART bank means an organization which shall be responsible for collection of gametes, storage of gametes and embryos and supply of gametes to the ART clinics or their patients. Infertility means the inability to conceive after 1 year of unprotected coitus or other proven medical condition preventing a couple from conception. Now, since ART has evolved so much and the age of marriage is increasing, we have made ourselves to reduce the infertility months to a period to 6 months of unprotected intercourse. Now, whether it will be allowed by law or not, it's a gray area again. But for all practical purpose, we take 1 year as per definition of the law. Coming to the ART clinics and banks. ART clinic and bank are two different, they are defined by the law. There are two levels. Level 1, where only IUI procedure is carried out as a part of treatment, nothing more than that. Level 2, where any or all of the following procedures are carried out: surgical retrieval of gametes, handling of the oocyte outside the human body, use of sperms for fertilization of oocytes, transfer of the embryo into the reproductive system of a woman, carry out storage of gametes of embryos, or perform any kind of procedure or technique involving gametes or embryos. Such clinics may also undertake research. So they are entitled to research also, but there are restrictions on the research which have been put in the rules, where the consent has to be obtained for research purpose. They cannot be sold, as it has been already told. So commercialization of artificial reproduction is absolutely prohibited by this act. ART bank shall be responsible for screening, collection and registration of the semen donor and cryopreservation of sperms, perform screening and registration of oocyte donor, operate as semen banks or oocyte banks or both, maintain the records of or data of all the donors, and shall regularly update the national registry as provided in sections of the act. So these are, in short, the most required definitions for us. There is a list of definitions, and I would request those who are going into ART clinic or gamete bank, they should read it thoroughly in every letter of it, because every letter of the act and the rules run into 64 pages. And every section has been clarified in the rules, and the flexibility of the law has been defined in the rules, which run into 64 pages. What are the other duties of ART clinic? The ART clinic shall ensure that all unused gametes or embryos shall be preserved by the ART clinic for use on the same recipient, and shall not be used for any other couple, or as the case may be, say woman. Allow cryopreservation of oocytes, sperms for oncofertility patients undergoing treatment and for other such conditions for duration longer than 10 years with the permission of the national board. So if you want to preserve the gametes for more than 10 years, you have to take permission of the national board. Ensure the controlled ovarian stimulation of women in order to prevent ovarian hyperstimulation. Now this is something funny the Act has to prescribe. This is a clinician's domain, whether to go in for hyperstimulation or not, HSS, and we are more worried than the law itself. But somehow I don't know. Maybe our own proxy representatives have made this to insert this, and I don't know what happened. But this is something I have failed to understand, why Act should prescribe that ovarian hyperstimulation should be prevented. Law doesn't know what hyperstimulation is. Neither the law doesn't know the clinical A to Z, anything of the ABCD of the clinical entities, but still this clause has come in. The ART clinic shall ensure that pre-implantation genetic testing shall be used to screen the human embryos for known pre-existing heritable or genetic diseases and women, and when medically indicated. This is what I said when the law says that every case must be pre-implantation testing must be done. The rules provide this flexibility. So it is left at the clinician's discretion whether to continue to go with PGD or other pre-genetic screening or not. Ensure that no pre-implantation genetic testing shall be done for sex selection, for non-medical reasons or selection of particular traits due to personal preferences of the prospective parents, or to alter or with a view to alter the genetic constitution of an embryo. So, experimentation of the embryo is not permitted in this. Coming to the other legal formalities, the consent and other consent forms. Informed consent of the couple must be obtained in writing in a language understood by the couple as specified in Form 6. Nothing more to explain. Consent is there everywhere. Informed consent is a mandatory thing in every invasive procedure. The other consent forms to be maintained are consent from IUI with husband semen or sperm as specified on Form 7, consent from intrauterine insemination with donor semen as specified in Form 8, consent from freezing of embryos as in Form 9, consent from freezing gametes as in Form 10, assent of freezing of gametes, sperm or oocytes as in Form 11, consent for oocyte retrieval as in Form 12, consent from oocyte donor as specified in the Act. These are a big bunch of consents every ART center will have to take out, print out and get them ready for every patient of artificial reproduction. Coming to the other formalities, registration must apply to the appropriate authority in the prescribed form and pay registration fee, which was previously 2 lakh, 5 lakh and 2 lakh, now has been brought down by rules to 50,000, 2,000, 2 lakhs and 50,000. A veterinary prices are for 5 years. No person shall establish clinic or bank without registration and must register with National Registry within 60 days of notification. The notification has come, but still there is confusion. Still, the National Registry site is open and the registration is available. It is a simple 2-page form with very few fields to be filled up. Take a printout of the filled up form, send it. Your duty as of today is over until the Act is implemented in its full force. The further things come up. The clinic or bank will cease to function after 6 months of notification. The notification is yet to come unless applied for national registration. I will clear certain points before going into further lecture. On the receipt of application, the appropriate authority within 30 days should grant the registration or reject for the reasons to be recorded in writing. Now the question arises, and the law is never clear on that. What is going to affect my clinics which are already running for 20 years? Like ours is running for 22 years, Sunita is running, started her Ruby Hall clinic, and many of hers started within 5 years back or 10 years back. What to do about them? Well, the appropriate authority, there are going to be only 2 appropriate authorities, national and state. It will be discretion of the state to whether to appoint appropriate authorities district-wise or not, or to authorize somebody on the health on the behalf of district to complete the formalities at a district level. And most likely, as my understanding goes or my perception goes, it will be again the PCP and MTP committees which will be authorized to and work for surrogacy as well as ART Act. So now these authorities will be entitled to give you, I wouldn't utter the word, but trouble is the real word for it, trouble under 4 laws. For those who are handling an ART center or bank, they will be suffering from 4 inspections at a time from the same authority. Coming to the staff requirement, they have been very specific about staff requirement. I am not going to the details. Those who are interested, the rules, if they want, I can always send them the 24 PDF of rules. But for level 1, only 1 gynecologist qualified postgraduate degree. That's it for level 1, where only IUI is to be conducted. For level 2 clinic, gynecologists or specialists in reproductive medicine with postgraduate in obstetrics and gynec. So obstetric gynec postgraduation is must. He should have had a specialist in reproductive medicine. Again, there are certain exemptions, those who have already worked or have been doing this and that. There's a big list of what exemptions can be obtained. I'm not going to details for time, constraint of time. Andrologist, a general surgeon with andrology training is a must. Senior embryologist with specific qualifications, he must have a PhD in embryology. Junior embryologist with a degree in biosciences, maybe life sciences. Counselor with a specified degree in counseling. And lastly, the anesthetist, of course, has to be qualified. The only thing is, Of these, andrologist has some exemption, and a gynecologist, of course, postgraduate, anybody but reproductive endocrinology diploma and all these things, or national boards, DNB and all these things you can at present. But again, there are rules have been framed so that those who are already working may be allowed to work. Those employees who are working may be designated as senior employees. And these things will crystallize as the law is implemented and at the whims of the authorities who are inspecting you. Whether he has to agree and how to convince him will be a further future exercise for all of us. Donor requirements. The sperm or oocyte donor shall be tested for following communicable diseases, namely HIV, hepatitis B, hepatitis C, syphilis, and semen culture to be performed in every sample which is to be preserved. So, no semen culture required in fresh sample if it is to be used, but if you are going to freeze it, its culture must be done. You send for culture, freeze it. If the culture is positive, you have to discard the sample. At level 1 and level 2, there is a huge list of requirements what is required. Again, I will ask you, those who are interested, to go to the rules, and they have been specified. I'm not going to repeat them or enumerate them, a big list of, but you have to go with that. And maybe the authorities will come and say that this is not available, so I'm not sanctioning that can happen. So we will be at the mercy of inspecting authorities. Again, I don't know what lies in future for us. What are the approaches? There will be a national board as national authority to guide central government and state boards and to maintain national registry. So the national board has only two duties: to maintain the national registry, to guide the center, to change, formulate or adopt rules as the need of the time may be, and control the state boards. Well, there will be a state board for each state or union territory to implement the act and register the active centers. So we will have to register ultimately with the state boards. They have to be formed within 90 days of implementation of this act, so the time is yet to come. Coming to the last part of the lecture, and again a dreadful thing, as if the doctors are ART center owners or the ART banks are the criminals, likewise. But this is only a deterrent, and it has to be incorporated in every law, as you know. So these are the offenses. Any medical geneticist, gynecologist, registered medical practitioner, or any person shall not abandon, disown, or exploit, or cause to be abandoned, disowned, or exploited in any form the child or children born through ART. Sell human embryos or gametes, this is a sort of repetition, but verbatim from the law. Sell human embryos or gametes, run an agency, a racket, or an organization for selling, purchasing, or trading in human embryos or gametes. Import or help in getting imported in whatsoever manner the human embryos or human gametes. Now, import means, does it mean only international import or import from some other center to one center? There is no clarification. The clarification will come in time. But a question was asked during the Pune Yuva ART to the speaker who talked on ART Act. Is a national permission required for transferring embryo from one center to the other? Is permission required from transferring oocytes, frozen oocytes from one center or bank to the other? No. Again, a gray area. From bank to other center, well, it's stipulated that bankers are supposed to provide frozen embryos or, gametes, not embryos. The ART clinics will freeze the embryos, but not banks. But gametes are to be supplied to the banks, so transfer is automatically allowed. What about embryos? There is no answer to it at present. Certain points of the law are not even decided by the rules, are not even decided by the practice. Only the courts can clarify the gray areas. Like in PCPNDT, many of the gray areas have been clarified. There is going to be a time when the courts intervene, when some NGO goes into and the employer says that this center is importing embryos from that center, and there is a litigation, and the court will say, go into the facts, and whether will allow or disallow transfer of embryos. We don't know. Exploit the commissioning couple, woman or gamete donor in any form. Transfer human embryo into a male person or an animal. This is a very imaginary problem anyway. But since women's male surrogacy has been practiced in some Western countries as a trial, this is not impossible. sell any human embryo or gamete for the purpose of research, use any intermediates to obtain gamete donors or purchase gamete donors. So if anybody is caught into this, it's an offense. Offenses under the Act are cognizable and bailable. I will slightly differentiate between what is cognizable offense and bailable offense. Well, cognizable offense means the cognizance has to be taken by the court. So you just cannot write a police have a discretion to dismiss the case, to dismiss the complaint. In this case, police don't have a discretion to dismiss the complaint. They will have to be submitted to the court, and court has to decide whether the complaint is admissible or dismissible. No court shall take cognizance of such offense unless complained by national or state board or authority so appointed for the purpose. Fortunately, it's a ray of hope for us. The NGOs won't be able to go against ART Center for this. Only the appropriate authority can send a complaint to the court or lodge a complaint to the police, and the police will submit it to the court. So I can't go against Archana's ART Center that she is malpracticing. She is not, I am sure. But personal complaints will not be entertained. Only authority has to complain. Only Metropolitan Magistrate or Judicial Magistrate shall try any offense committed under the Act. So this is a cognizable offense, has to be tried by Judicial Magistrate. But it is bailable. So is a right in these cases. So when a complaint is lodged, either the court will grant bail immediately, if convinced so that this person is not going to tamper the records or is not going to cooperate. If he decides to cooperate and if the records have already been confiscated and the court feels that there is no need to keep this doctor inside, then he will immediately grant the bail, or the police officer, if his complaint is lodged with him, can grant the bail under certain sections of the Criminal Procedure Code. What are the penalties? Whoever contravenes, this is again the repetition, with a fine which shall not be less than 5 lakh rupees but may extend to 10 lakhs. 10 lakh rupees for the first contravention, and for subsequent shall be punishable with imprisonment for term shall not be less than 3 years but may extend to 8 years, and with a fine not less than 10 may extend to 20 lakh rupees. Well friends, as I told you, this is a very high and dry lecture. And two beautiful lectures with full of graphics and information are coming up, so we are ready for that. But this is the only graphic I use because after every medico-legal lecture, this is the scenario. Either they wake up or you can see the man in the middle. He is totally confused. What am I supposed to do? Or rest of the people are ignorant. They go to sleep and let it happen. Whatever happens, I am going to sleep. But we have to be aware of the law. As you know, every citizen of India must know every law of the land. This is a law we practitioners must know. And this is only a glimpse of the law. As I told you, the law runs in 16 pages, 36 sections. Rules run in 64 pages, explanation to every section. If you get a time, try to read it. The legal language confuses you, go to the explanation, the rules. As and when certain gray areas will be cleared by the courts, we medical legal experts keep you updating. Until then, until the law is notified, let us run our centers peacefully. Once the authorities come into appropriate, let's be ready for them, whatever the circumstances come. All the best of luck for those who are aspiring ART centers and running ART centers. Thank you very much.
Thank you, sir, for making us a bit easy to understand this act. Now one question. So everybody who are doing IUIs, we have to register with level 1 ART center.
Level 1 ART center.
And who are doing IVF, they have to be registered as level 2.
Level 2 ART center.
So initially it has been mentioned that from the day of commencement of the act or from the day of commencement of the national registry, we have to register in 60 days. So that has come into the act from 21st April.
15th of April. 15th of April and 15th of June they say will be the last date. But again, that is not really explained by anybody. The site doesn't explain that thing. The site only provides 2 pages of registration and only the number of how many registered center, how many accepted, how many rejected, 0, 0 and some 500 or something.
It is entirely 0.
Yeah.
But is it the deadline 15th of the June?
Yes.
As per the rule?
As per rules, they say because the rules have been published and we will have to submit them by 15th of June. Or 20th of June, I suppose, because rules were published on 20th April. Yeah.
Yes.
Yeah.
Thank you, sir.
But still it is not notified, so it's still the gray area. But it is better we register them, whether it is they accept it or they will accept it. And whether it is, and will be comfortably allowed to practice for 6 months because we have done our duty.
Yes, thank you, sir. Any questions?
Thank you very much. Technically, no. You will have to have two different establishments. They can be in the same building. Nobody can say that. They cannot be, but the IVF center cannot run the IVF bank. It will have to establish another IVF bank as an entity. That is what is the current understanding of the law. As I said, there are certain explanations that they don't come into it. And it will be at the discretion of the, and we are really at the mercy of the authorities. If they say that if your bank is in the side room, I won't allow it, we are helpless at that moment. So it is going to be resolved as the time comes.
If we submit the form, it is mentioned that take out a print out of that submitted form and send it to the appropriate authority. So, but nowhere it is mentioned to whom we should send.
I think there is an address where it, and the address is provided. I think so.
Okay.
Yeah. Well, I will let you know the address. Those who are in dilemma can call me, no problem.
And the second question is whether the IVF centers are allowed to give the prepared semen sample to other.
Not in the current law. IVF center, IVF,
is not
ART
mentioned.
clinic will not be allowed. But ART bank will be allowed.
Okay, so
It is only the prerogative of the bank to supply gametes, not the ART clinic.
because many of the gynecologists they ask for the wash sample, IUI sample.
They won't be able
for
to
the
do
IUI.
it. No.
So it's not allowed in the
No.
law.
Even there is no clarification whether the pathological labs will be able to process the semen and supply the process sample. That is not clear in the law because pathological laboratories are nowhere mentioned in the law. Again, it is going to be a gray area which will be resolved by the whims of the appropriate authorities.
Can I say something, Girish?
Yes, please.
First of all, you presented so beautifully. I know it's very boring subject, but we all need to understand and we are shaken up. But as a ISAR organization, we are working very hard in it. And on Friday last week at Puri, Dr. P.C. Mahapatra with Nandita as ISAR president, they have organized again a meeting to discuss the ART bill. Overall, what I feel is the egg donation is going to be a very tough because there are so many criterias and you can't give compensation. But for a surrogacy, compensation they have allowed now. So doing a surrogacy, because those who are filling up the form, and probably 2 months ago, I was absolutely, or a month ago, I was very strict. I'm not going to take surrogacy at all. Neither at DPU nor at Ruby Hall. But now, surrogacy, they are allowing the compensation. What compensation and how much is the prerogative of the couple and the agent, right? But with the egg donation, there is no compensation. And that's going to be a very big challenge for all of us.
Yeah, but the ART banks.
How ART bank will also be able to survive
That is-
if
yes.
they can't give a compensation. And recent incidents in Ruby Hall, I can see that as long as everything is fine, that lady went and put in a police that I have procured all false certificates. And she could manage to get even Aadhaar card and everything false certificate. Now, as a doctor, how we are supposed to know these are real or false certificates? So it's going to be a very, very tough.
That's actually is the defense of the Ruby Hall doctors, and that's going to stand in the court of law, I tell you, because we are not any verifying authority, and the false documents are supplied by the government agencies or they are falsified by some criminals. We are not responsible for that. Anyway, but as you are telling, I know the authorities or our seniors who are in FOGS-CME and ISAR are working hard to bring in some favorable changes. But how far the people at the law commission level understand it, I really don't know, because
No, but I think the first draft which was there and the rules and regulations
There are
which have
different-
come,
there are lot of
from
differences
7
there.
they have allowed us to
Yes.
go till 14, 15. So I feel that they are listening to us, and we
And see,
hope.
the rules are,
It is the President of India who took an interest, who gave 3 hours to the ISA team, and they heard everything.
Yes.
He called up Supreme Court judge. Now, those people are not aware anything
They're
about
not
the
aware, yes,
ART.
actually.
And that's why this all mess up has happened. But at least there is someone who is listening. But we all have to understand it is here to stay, and we have to accept to live with
with
this
these
way.
rules, yes.
Yeah.
And just a consolation to all of us, the rules are, see, the rules are not to be passed by Parliament. The act is passed by Parliament. The rules are passed by the specific committee. And the National Board is meant for that, to assist the central government in formulation of the rules. So rules are subject to change from day-to-day level. And they will be ratified by the Parliament later on, no question about it. But there is no discussion on it because they are recommended by some authorities and they are recommended by the National Board. And maybe if we people over the years are able to bring favorable rules to us, that will be good for us.
Thank you, sir.
Thank you.
Thank you, sir. I request Shashika Numardhan sir to felicitate Dr. Kumthekar sir. I request Jamma ma'am to felicitate Shashika Numardhan sir. I request Dr. Vijay Pawar sir to chair this session. Welcome, sir. Dr. Vijay Pawar, sir, he is consultant at SIMS Fertility Center, associate professor at VM Medical College, and unit in charge. He is ex-clinical associate region assist center for ART, endoscopy, and fetal medicine, fellowship in ART, and fellow of minimal access surgery, India. Over to you, sir. Thank you.
Very good evening to all of you. I will be short and sweet. I don't want to waste any more time for inviting today's speaker, Dr. Sunita Tandulwadkar, madam from Pune. We all know about her. She is our very own from our Solapur VM Medical College pass out student, currently heading the department of OBGY at Ruby Hall Clinic, Pune. She is the chief IVF consultant in Ruby Hall and Endoscopy Center, Solo Clinic. She is also now the new, she is the director and chief advisor at D.Y. Patil University, Pune, and I would recommend all of you to at least see the DPU center. I have seen it on the video, and in the next few months I am planning to go there for seeing the center. It is one of the state-of-the-art center, because I think Dr. Sandesh Kade had gone to see the center and he was really mesmerized with the things that are available over there. So you name it and it is available there. So whatever is available all over the world, latest technology, everything is madam has put into that center. And I think in the next few 2-3 years, I will not be surprised that that center will be the center of excellence all around the world, with madam leading the center. So that was regarding the introduction, and I would like to ask them to play one video for madam. This is the give back to the alma mater, that is the VM Medical College, the gratitude that madam has shown to donate the laparoscopy unit to our very own Dr. VM Medical College, Solapur. So today we had the inauguration function. So some of you had attended the function. So we just want to just capture the event. So the operation theatre has been named for under Dr. Sunita Tandulwadkar Madam Laparoscopy Unit. We had the inauguration today at 3:30 p.m. So this is Striker 1588 high definition endoscopy unit. So all the instrumentation and everything has been given by madam for the residents. So this is what will inspire for all our young residents to be like a benchmark. It is like our gold standard, like we say Birch repair is a gold standard. So here also madam is like a benchmark, and I would always be happy if anybody can break madam's record. So very, very happy if somebody, it will be a challenge for the residents to break the things that madam has done in her career. So this was the event today. It was attended by all of them. And Dr. Rajesh Tandulwadkar, I don't see him here around now. Sir aptly supported the woman in his life. So woman empowerment, if you see, that is what you can see when I see madam. She is like a solo person and highly empowered lady. So that is what I see always, and I always get inspired by her positiveness. Every time in any doom and gloom situation also, she will be so positive. This inauguration was also landed in trouble. There was some starting trouble because we had an all Maharashtra strike of the nurses. So we were very skeptical that today this program will happen or not. But when I called madam that we may have to postpone, so madam was so positive that we are going to go ahead with this, and ultimately with God's blessings, the strike somehow ended 2 days back before madam's arrival in Solapur. So this is the way you have to think positive in life. Even if there are some negative things, it will happen if your intentions are good. So this was the inauguration ceremony. And now I invite Dr. Sunita Tandulwadkar Madam to for her today's talk on endoscopy.
And mainly Madam Sardesai. They are my teachers, and what I am today is because of them. It feels so great to come back to your city where you are born, and I always feel tremendously proud of that I belong to VMMC Solapur. Thank you so much. Solapur is too good. So friends, can we have the lights little off? Dim out. Bala Sahib, light hai kamera na. Mastering the challenges in endoscopy. Endoscopy is my passion. I think in the year I passed, 1989, world's first hysterectomy was performed by Harry Rich, and the news had come. And those who have passed out from VMMC, I know, they all know in their mind that in 3 years, the amount of hysterectomies and cesareans they do, that they feel what next. And that's what has happened with me, that after hysterectomies and cesarean, and after passing out MD, what next? And then the endoscopy came in my life. So first of all, thank you, Dr. Jamma, the president of Solapur OBGYN Society, Dr. Archana, my seniors, Dr. Rohini, always there with one phone call, and my batchmates and juniors, Bharti, Raju, and Girish, my lecturer. It's so lovely to see you. Believe me, when I work in Pune, I miss this atmosphere of our residency. So thank you for being with me here today. Friends, endoscopy has given us the chance to be creative. So we all suddenly became creative, and I'm going to show you few videos about myoma. We all know, every surgeon, even in this city, I know that 10 surgeons must be operating the myomas with the 10 different ways. What is important is prepare yourself well before each surgery to excel your performance. I think when there was a Solapur ke saath webinar, I showed many of these videos. So I'm going to bypass and I'm going to show you another video. But this is what the mapping of the myomas we do at Pune. There is Dr. Tandulwadkar, the fantastic surgeon. I don't need an MRI 99.9% of the time. This is what the mapping. Now, how does this mapping helps me? One, it gives me a decision or a counseling to the patient. For example, there are myomas where I'm going to have compression from all the 3 sides. I probably will explain the patient that I may not be removing all the myomas if I open the cavity. Sometimes the myomas may be very big. I may be concentrating while these small myomas doesn't give any protrusion or projection on the serosal surface, and I may not be able to remove them. It's very important to counsel the patient. Of course, your team is all the team members. So these videos, I think I just want to forward it, but I want to show you another video. These are the myomas, for example. The patient is for the frozen embryo transfer. They are the multiple myomas. I can't even see. She had a previous endometriosis surgery, all bowels completely compressing. The best energy source is no energy source. Don't have assistant's hand coming. All the small bowel, they will be all flattened up. You pull them, they may give off. So very important that your scissors and you doing entire job all the time on the uterus. And just open up. Fiber by fiber dissection is the one which we need to do. So if you see, I'm pushing the uterus. I'm never pulling the bowel loops. So this is very, very important. Now these fibroids I can't even see. What is important is I need to do complete adhesiolysis. Adhesiolysis will take my half hour, 40 minutes, 1 hour. Myomectomy is simple. I have to just incision, enucleation and removal of the myoma. So even if you are started seeing small myomas, don't jump, because once you remove the myoma, there may not be a flap available for a closure. The sigmoid colon is densely adherent. It's very, very important that you separate out that completely, and then only you can proceed. Now this patient had an associated hydrosulfing. When such a frozen pelvis is there, always open up the lateral pelvic wall just to see where the ureters are. Can you see that? The ureters are just laterally here and they are not pulled up medially. Once you see the ureter, removal of the hydrosulfings, removal of the fibroid is very simple. 1 myoma, 2 myomas, and there was a right-sided broad ligament myoma. I will definitely go and remove that myoma as well. So this is what is your preoperative diagnosis. Mapping helps you because in laparoscopy there is no tactile sensations there. Now sometimes the myomas may be very big, 20 centimeter big myomas, and she has associated these two. Now to my patient I told this myoma doesn't give any bulge. I'm not going to touch. I'll remove this myoma and I'll remove the other 2 myomas. So if you see, this is the big myoma, then there was a myoma I'm removing. So if you are fast in your enucleation, when the vasopressin action, which is supposed to be only for 20 minutes, you will have a complete bloodless surgery. Because symptoms, the procedure is same. Incision, enucleation, closure of the flap, and removal of the myoma. Now this is a big myoma. I'm just taking an incision and I'm removing. Only when I remove these two anterior wall myomas, I can see the posterior wall. And I can see this bulge. I removed that. But my patient was very clear she was interested in this myoma. So 2 centimeter below and 2 centimeter laterally, I'll take the incision and I will take out. So preoperative mapping helps you. For example, such a large myoma, 30 centimeter, anterior wall. Now if I take a central cut, I will open up and I'll have a big dead space. So what I will be doing in this is, I will take a U-shaped incision. Instead of a vertical in the center, I may go U-shaped incision, take out the flap also with the myoma, and then do the closure of the myoma. So again, it helps you to see, but I want to show you which I perform just 3 days or last week. The another case, very interesting and very challenging. Now you see, these myoma, if you see very clearly how preoperative helped me. Now can you see this is a pedunculated, but this has a broad base, he has told me 5 to 6 centimeter, while this was also pedunculated. Now this fibroid was up to the zipisternum, the other fibroid which was 15 centimeter up to the splenic fracture little low down. So I know that I am going to enter from this space, this is pedunculated, and this posterior wall which is around 10 centimeter, I will not be able to see unless I remove this. So this preoperative mapping helps you. So if you see the uterus obviously all distended, right hepatic, left side, it's all, these are your ports after the surgery, and when you enter in, you will see entire fibroid. So what is important is you need to go absolutely determined and disciplined in this case. Yes, how I'm going to approach. First thing is I don't keep 20 cases on that day. I keep complete 4 hours, so I'm not in hurry. I book my operation theater for 4 hours, so no surgeon is sitting on my head. And once you enter in, you just examine and confirm your preoperative diagnosis. Of course, when you are seeing from a zipisternum, that right-sided, which was up to the hepatic junction, it may be very difficult. But then you know this was a pedunculated, there is one accessory fibroid there, this is another 5 centimeter, how I am going to take out. So first thing is just put the loop. All the vessel channels will be too big. Don't allow only one loop, always put 2 loops, because after some time the first loop will become loose, and then you take out that myoma first. Just you cut it out and remove. Then I'm going for a second myoma. Again, though it was a 5 to 6 centimeter, there is no harm in putting a loop. Little vasocompression, it will help, because such a large myoma, you cannot do vasopressin injection at all. And all the big vessels will be at the base. When you are cutting, forget about it, you just proceed. I just edited out, you can see the loop has become loose. And this is now the 10 centimeter myoma with the myoma screw. From the posterior wall, you lift out. And this is completely that third myoma. So what is important is nothing is impossible. It is your mind game. You need to go determined and you can play. But at the same time, see that medico-legally you are safe. Don't do this surgery unless patient is giving you a consent of an open surgery, whether open or laparoscopic, doing the best job. This patient had come from US. I was going for an Indore. I told her I cannot accommodate her. She needs my half day. She stayed back for 1 month and we could operate her last week. So this is important. Myomectomy may be little simpler. Taking out these 3 myomas is a huge job. So if you see fibroid, number 1, you need to have a good assistant who help you for a morcellation. This is a second myoma, which is up to the up, and then this is a third myoma. So it needs your patience to take out, but you need to do very good job and end result. Of course, this patient don't wanted me to do the mini laparotomy to take out. She was a nulliparous lady, 42 years plus. Vagina was very narrow, so we have to do complete morcellation, giving her very clean end result. This is what I wanted to share with you before I proceed with my lecture. Because I gave this in a Solapur Society with this, I thought of editing because we do all complicated myomas with us. This is what, again, another big myoma, but vascular pedicle, very simple to operate. It looks big. It is occupying this, but it is the most simplest myoma because what it needs is only 2 loops and then your fibroid is out. You can see these all big vessel channels. They are opening up there. You have no choice then. When you start cutting, what is very important, when you start cutting, you will have a lot of blood flow coming from the myoma. Don't bother, don't stop. Bipolar works fabulous in presence of fluid, whether it is a water or whether it is a blood. This is all the reflux coming from the fibroid side. Your speed of a surgery matter because you have a lot of time to do the morcellation job. So just cut it out and you will see that everything bleeding was happening from the fibroid, whether in a previous case or whether in this case. The loop makes our life very simple. Now, what about the hysterectomy? Do we face the challenges? Of course. These are the uterine manipulators which I designed way back in 1994-95 and I'm still using them. They can lift up the uterus of any size up to 24 to 26 weeks uterus. The third hand in the vagina always helps. Now, what is the trick of hysterectomy is make apparent lengthening of all the ligaments. So, if you are working on a left side, push the uterus completely on the right side so that you have an apparent lengthening. Your cameraman should be very good. He or she should be showing you what you want to see. The above uterus, maybe 20 weeks or 30 weeks, makes no difference to us. And am I supposed to do uterine at its origin, which has little bit become a fashion in India? Please no. Don't complicate the simple case. You can see now the lateral vaginal wall or the lateral pelvic wall is so far away. The ureters are moving here. The uterines are so obvious. They are there. I'm not going to go to the lateral pelvic wall to take them. I'm miles away from the ureter and I'm going to perform the whole surgery. But in case if I have to do, it is an unedited video. It just takes you 30 seconds. You just take one coat, one vertical incision. All the important organs, they travel vertically, whether it is ureter or the iliac vessel, except the uterine, which is going to traverse. So just spread your finger on both the side, caudal and cranial, and you will have the uterine going there. Just don't jump saying that it is uterine. You confirm its origin with the internal iliac and it's bypassing with the ureter. Sometimes there may be anomalies. Sometimes it may be a superior vesicle. How big is big? This is up to zipisternum. Now this is in your mind. If your camera is above, giving you 2 to 4 centimeter vision, then you can operate anything. So if it is a 10 weeks fibroid, you are at a umbilical area. If it is 20 weeks, you are 4 finger above the umbilicus. While you are up to the zipisternum, you will still go very high up. So this is the uterus with multiple fibroid. Now this is a teacher from Pune and she was scared to undergo surgery. Everyone told her open and that's why she allowed till she became breathless and she cannot walk. Of course, open surgery consent is mandatory. What is here is when I use 3D, I don't like 30 degree. It becomes a difficult surgery. So when you are operating on the left side, have your camera and 2 ports. You don't need assistant hands. It is only your 2 hands and the cameraman plays the role. I still put the uterine manipulator. It helps me. Then there are big vessels. When your all ports are very high, it becomes very difficult when you are reaching to the pelvic peritoneum, anterior pouch or a posterior pouch, because the length of the instrument doesn't so then you go on a right side, put your all instruments on a right side and operate. So you will see that it is a bloodless surgery all the time. I love to do bloodless so that everyone enjoys. And for that, you coagulate and then cut. Then the job is simple. So this is how you can just do the laparoscopic hysterectomy for whatever. More difficult are these cases where you have a broad ligament fibroid, you have a cervical fibroid. They may not give you upward too much of a length in the abdomen, but they are horizontally spread. These are more difficult because you are near to the lateral pelvic wall than the one which are vertical and giving me 2 finger space or 3 finger space on the lateral side. What is again examination? You will see I never jump for a surgery. I confirm, I see the patient, she was a dancer, she always needed only laparoscopic surgery. So friends, we don't grow when the things are easy, we grow when we face the challenges. And this is again endometriosis, previous open surgery, then she had 2 cesarean, and I cannot even put the right-sided port because all the bowels are densely adherent. What is important is, again, a non-traumatic bowel grasper and a good Caesar. Don't have very sharp Caesar also. You also don't go too much into the peritoneum. Try to be on those. How in an open surgery with the scissors, we used to swipe and do it, swipe and cut. The same principle applies. All open surgery principle are in a laparoscopic surgery. Just small fiber by fiber dissection is the key, and the anatomical landmarks, medial obliterated ligament, they are the one which helps you. And if you go too much with the fear in the anterior abdominal wall, you will go into the extraperitoneal spaces. Now if you see, we all know previous surgeries, we do the bowel preparation and you see how the gas went off. So very important that you correct and then remain in a beautiful plane. When you go down, you will find that there is no uterus you can see. So always start from a left paracolic gutter and keep on coming down. Again, when you start dissecting, the planes open up on its own. CO2 gas helps us. In laparoscopy, you should be bi-handed surgeon. So you can see I'm just using my left hand grasper and right hand Caesar. In open surgery, we were taught always Caesar in a right hand. In laparoscopy, we don't follow that. Whichever hand you are, you just need to use Caesar as a grasper, Caesar as a retractor, Caesar as a dissector. Automatically, few principal changes. What is important is remaining in a good plane, and then I'm seeing a small part of a uterus, probably the left-sided obliterated medial ligament as well. I'm taking the cuts on the loops of bowel. One wrong cut and you open up the bowel. It's not that you cannot suture, you can suture, but probably the post-operative morbidity, more closer observation, her increased stay in the hospital, which was undetermined, was absolutely the problem for all of us. And once you do this bowel dissection sharply, then you enter. Now, previous to cesarean, frozen pelvis, I love to go and take the uterine at its origin, and then I will traverse and I will finish up on the opposite side also, the similar way, and then always go to the vault as the last. Sometimes, again, huge fibroids, more difficulty goes in a morcellation or vaginal cutting, especially if the patient is nulliparous. You can see this was a trocar which has done, and you have all the fibroids. These multilobular, more or less they are the same. Here, instead of a bipolar and a harmonic, I'm using this bipolar cutter scissor. So, job is simple. I can use only one hand and can do. There was no space for the 2 hands. So, with one hand, you do the bipolar, open up, make the space, and then you have this bipolar cutter which makes life simpler and more economical to the patient. Of course, you can charge the cost of a harmonic. Instead of patient paying for the harmonic, you can. You can see my uterine manipulator has given me a beautiful space on the left side, and that's why even if it is going halfway, I will always go and use that. And this is how we are doing on the right side, and then the surgery we finish. So, how big is, I'm just bypassing the frozen pelvis, how big is your mind? Once you conquer, we started in an era where in 94, 95, we had single chip camera, then came the 3-chip camera, then the HD system and 3D system. Now when last 5 years I'm working on 3D system, believe me, I'm absolutely not able to do level 4 surgeries with 2D system. If the 3D system is not available, I don't operate on that day. And that's why I made rule that 3D system is booked for me for 4 hours, because I can't work with 2D system, because we become habituated and now we think retrospectively. I don't know how in 95 I used to do hysterectomy. So friends, especially the youngsters who are sitting here, spend money in the machineries, because endoscopy is a surgery of technology. You may have a simple Maruti 800, but have a best of the system and the energy sources in it. Then once you become a master, the BMW will be walking to your doorstep. Robotic. After the 3D, the robotic came. Actually, I don't know whether I wanted to learn robotic or whether it was a pressure by the CEO of our hospital that if the robotic has come and you are not doing it, how this will be. And that's how I entered in training for a robotic, because I was compelled to. And believe me, it's a fun. Only you need a time. Do I advise robotic for a benign fibroid or hysterectomy? Probably no. But robotic has a less learning curve. Challenges are what makes life interesting, and overcoming them is what makes life meaningful. And if you remember these lines in your mind, every challenge, you will go with the happy mind. So which are the surgeries I love to do is tubotubal anastomosis. Pelvic floor, reaching it to the levator ani, because these hand instruments, they move with the 560 degree. So it's as good as open. Those who are master in open surgery can learn robotic in just 2 days. There are beautiful centers in India where you can go to Kochi or Rishikesh and you can learn this robotic surgery. This was my first tubotubal anastomosis. My patient, frankly speaking, she was undergoing divorce at 12 weeks of pregnancy. I probably have done the worst counseling in my life. I don't think I would have done any time. Worst means, for the patient it was worse because they wanted divorce and they wanted termination of pregnancy, and I wanted on my name robotic tubotubal anastomosis, your first baby delivered. So I left everything. I did 1 hour counseling, how it is important to survive and keep the marriage going. I gave them an appointment after 1 week, come back. I ensured that they don't take divorce. She carries the pregnancy to 9 months. And I deliver her, and now that baby is 4 months. So probably all ART consultants are the best counselor. Raju Dabde is one of the best here. He knows how to do the best of a counseling and lead in the city. We all become, but this is the requirement. Sometimes you do the counseling to save the marriage, to save the baby. And we decided I will do only one side because we'll take a lot of time. And I finished in nearly 20 minutes, and that's why we did bilateral tubotubal anastomosis. So have I immediately sat from Kochi to know? No, let me tell you, I worked very hard. I used to sit at 9 o'clock in Ruby Hall Operation Theatre with the robotic with 1 tomato. And I used to peel off the tomato, and then I used to take 50 Vicryl and I used to suture those peels. And I did this for 1 week every day in 9 to 12 session with the sisters in the OT, specially appointed ward-wise in the OT, who will help me in all other things. And we did this practice, and believe me, that's why you excel. So it is the practice which makes you expert in the world. Hysteroscopy. We talk always about laparoscopy. This is a patient with 10 centimeter submucous myoma. I'm justified to do it laparoscopically, but this was unmarried girl from Saudi Arabia. I cannot take a cut on the uterus, anterior, fundal, posterior, especially when she is not going to be with me. And I know Saudi people, they have 10 kids. And I don't want it to spoil my reputation of rupture of uterus. And that's why I decided. So first we did a mini hysteroscopy where I saw where the base is coming. I'm not closing the loop of a finger. Open vessel channel. So even if you use a bipolar and normal saline, you are going to face with the fluid overload. Your speed of a surgery matter. I never wait for these all pieces to take out. It makes your field completely bloody. I just keep on resecting because I know entire cavity was just the myoma. And once I feel, this is near unedited till here, and once I feel, you can see 10 centimeter long pieces with the beautiful cavity 50% out, I just take a right turn and I will resect. So don't close the finger, just use your elbow and just keep on having a speed. What is important is having a good ward boy who doesn't allow you to finish with this. He keeps on changing the bottles before the bottle ends. This is a very old video of mine, maybe 2004. So performing hysteroscopy is like a painting on a canvas. You can see this adenomyoma protruding in. 2000 to 2006, I think this was a Versa scope with the Versa point I enjoyed. This was the first bipolar energy which has come in India. Afterwards, Johnson & Johnson has stopped it. Now this is an adenomyoma. What I'm doing is I'm framing that adenomyoma so that beyond this frame, I will not go anteriorly or posteriorly so that I will not perforate the uterus at all. And laterally, the cornus are helping me to show where I should be. This bipolar energy source, this Versa electrode, whenever I go to Europe, I buy and come back with those electrodes. We don't get them now in India, but what they used to do is they used to dissolve the tissue. But the disadvantage is you don't have the tissue for histopathology. And second thing is it gives you a lot of bubbles. But over the period, you become expert in managing the bubbles and taking out these. And you keep on doing what more we can. So another important thing, if you want to progress in endoscopy or any field in that matter, is don't say, I have reached to the top. You have never reached to the top. You always ask yourself before you go to bed, when was the last time you did something for the first time? This is very important. You need to be creative. You need to be innovative. And this is what unicornuate uterus, we all learn, me, Raju, Girish, Rohini, we all have been taught that unicornuate uterus, first she will have 3 months, then 4 months abortion. We used to counsel our patient, abhi tumhara 4 mahina ho gaya, next time tum 6 mahine tak jaogi. Because every time the volume of the uterine cavity was increasing. So always have a habit of sitting with pen and pencil at your study table. I used to draw the diagrams. When I was new, I probably never had a time to party. I used to always think what more I can do. And I thought, why repeated abortions of increasing gestational age? Why I can't think of making the cavity bigger? This was in 2007. We had an award-winning paper that time when we presented. This is what we decided. Why not? I can increase the cavity. The only problem was whether we can maintain the cavity. So give a estrogen and progesterone and see what happens. So this is what the unicornuate uterus we all saw. Now we call this as a lateral metroplasty, but I do fundal. So I change tubular cavity into triangular. And this is how we go. I usually like to take little blunt scissors for either intrauterine adhesions or such cases so that I don't overcut or I don't perforate where I spoil her obstetric career. So again, the principle remains the same, fiber by fiber dissection, and you cut out those fibers, and then what is your aim is convert tubular into triangular. So you have to imagine where will be approximately the cornu if she would have been a normal uterus and go towards that cornu. So again, the cornal opening is your landmark in these cases, and the cornal helps you to decide where is the fundus, where is the contralateral cornu, and then you can do the job beautifully. So this is how you can see the white cavity and you can see the pink cavity. Again, I used to think whether there are blood vessels or there is only fibrous tissue. You decrease the intrauterine pressure. You can appreciate now it has become a triangular. So decrease the intrauterine pressure and see whether the blood flow is coming, and it comes beautifully. Then after 6 weeks of estrogen and progesterone, I never like to put any devices. Even today, I don't put any devices, though I know there are certain people who are advising and some people are following it. I was learned in my residency that anything you put intrauterine and hanging outside, you will cause ascending infection, and I will never like to have an ascending infection. So you can appreciate the cavity has become bigger. You can still cut that and make a third look, your hysteroscopy or your 3D sonography. So before I go into this endoscopy and challenges and I end, as I said, after climbing a great hill, you find that there are many more hills to climb. You never reach to the top, and I don't want anyone to reach the top because afterwards it is a downfall. None of us wants to go on a downfall, and that's why I try to see many more hills. Another 3 minutes, a mind is like a parachute, doesn't work unless it's open, and this is the stem cells which we are talking about, regeneration of the ovaries and regeneration of the endometrium. In 2015, I entered into the autologous bone marrow stem cell therapy. Frankly speaking, it was not for me, it was for to save my mom. I started doing stem cells to regenerate her pancreas and kidneys, and I realized the function, the tremendous capacity of the stem cells to regenerate any organ you put into, and it's massive. And only problem is we don't know how to select the patient. We have the patient, we don't have a knowledge. Scientists have a knowledge, they don't have a patient. The day we all work together, probably we will do many more miracles. But regeneration, we all face decreasing ovarian reserve, and during that time, these are the publications of 2000 to 2015. These were the publication I used to read about. Autologous stem cell therapy can differentiate into primordial germ cells. You can make a haploid gametes in a male as well as female. And that's where, again, I went in and I did this autologous bone marrow. She was a scientist. In 2017, we did her bone marrow derived stem cells ovarian regeneration. This is Dr. Sanket's vasopressin needle which he designed. I love that because that can prove that I have taken a bone marrow which looks, the stem cells which looks like this, and we injected into the ovaries and we regenerated her ovary. I did her pickup in 2 times. I got 1 egg and then 2 eggs and 3 embryos we could make out of her, and we got this. Again, I'm thankful to human reproductive science. I don't think I would have made it a world record. I had submitted as India's first stem cell baby for a publication, and I received a phone call from a chief editor then, Dr. Madhuri Patil, that why don't you write one review article on stem cells since you are working. And we realized everyone in the world was working till the age of 40 and ours was a 45, and that's why we could label it. So this is an autologous bone marrow where we remove it, and we initially used to take out 100 cc, now we take out around 150 to 200 cc. So per cubic ml stem cell concentration you can increase, and you can have an automated stem cell to your. Now if you think you can regenerate the ovary, why not regenerate the endometrium? India full of tuberculous cavities. Endometrium, it's not possible for everyone to go for a surrogacy as an option. So friends, if you don't challenge yourself, you will never realize what you can become one day. And that's how we started doing for a refractory endometrium, very thin endometrium, 3 mm, not growing, or tuberculous, or repeated curettage causing Asherman and not able to correct. These are the cases which we did it. So I think by now at least 5 to 6 publications we have. We just are getting done with the natural conception also after the stem cells. What is important is these are the patient. First is you create the cavity. Now here we prepare the stem cells beforehand. So you need to be confident that you will prepare the cavity very well. That is a little risk I take with, but then I don't have to wait for the stem cells to come for 2 hours. So this is how you are creating. Now when you are going to do the stem cell, very important, create as much as you can. You may need a second sitting of stem cells as well as second sitting of a intrauterine adhesion release. But in a first go, you can see the cavity, just do the adhesiolysis as beautiful as you can. And when you reach out to the cornu, can you see that? I can see the opposite cornu. So I know I have reached to the end limit. So you just finish there on that side. When you can see both the corners, you know where the fundus is lying and where you should have your end result. This is the cavity wants you to maintain this cavity of tuberculous endometritis. We did a stem cells and then we did a second look hysteroscopy after 4 weeks. And I want you to see this beautiful picture of a second look. Can you see? I can see still the cavity has adhesion, but these are flimsy adhesion. Before the era of stem cells, I never used to have such a beautiful cavity back. This is pink cavity, number 1. The adhesions are pink, very flimsy. My uterine cavity, the opposite cornu is maintained. The lateral wall, the cavity is quite roomy, and I am quite hopeful for this patient to proceed. So I can just give her a estrogen progesterone, or I can do the second look therapy depending upon where the patient is. And this is our publication which we did. So friends, I just wish to say, expect the unexpected, believe the unbelievable, and achieve the unachievable. This is what the goal in your life. I humbly request you to support me for my presidential candidate. It's far away. It is September 2023. But I request, I know, I need your support. Thank you so much.
Thank you, madam, for the excellent talk for today's evening. It was highly inspirational and for all of us, and I hope one day one of my residents from VM Medical College will definitely break your record. So I'm sure about that.
Thank you. And we discussed that in the
You can see
evening.
the preparation madam is contesting next year. Still long time to go, so that is the importance of preparation before actually contesting the election. So best wishes for the elections, madam, and our society will definitely support you, madam. Any questions from the audience?
It's not only the elections, I feel. If you want to preside the organization, it's very important to go meet the society, see what are the problems, how the societies function. In Maharashtra, we work differently. In South India, we work differently. East India, Assam, they work very differently. So it's very important that you give a justice. Thank you.
Any question from the audience?
Thank you, sir. Thank you, ma'am. I request Vijay Pawar, sir, and Anjali Jamma, madam, to please felicitate Dr. Sunita Tandulwadkar, ma'am.
I request Jamma Madam to please felicitate our chairperson, Dr. Vijay Pawar, sir.
Yes, he is practicing since 41 years. He is ART consultant since 20 years. and proprietor at Kasturi Nursing Home and director at Navjeevan IVF Center. Welcome, sir. Over to you.
Thank you. I have a great pleasure to introduce Dr. Chaintanya Ganapule. Within a very short span of almost 6 months, I am introducing him the second time. He is a MD OBGY, Diploma in Gynecological Endoscopy, IVF, he is in ART, he is a director of Pearl Women Hospital and Yash IVF, Pune, Director Noble, Yash IVF. He is going to speak on endocrinology of male infertility.
Hello. Hello. Good evening, and at the outset I would like to thank Solapur OBGY Society for giving me this opportunity to be here today in front of you again within a span of 6 months and discuss my views on endocrinology of male fertility. As madam said that she is born and brought up in Solapur and she studied in Solapur. I am getting that feeling now, Solapur is likely to be my second home as well. I am coming to Solapur so frequently that it's like a second home to me. With this, let's start with today's discussion. I thought of discussing a little bit differently this time because most of the times we discuss about the investigations, the management of male infertility. So I thought let's discuss something about the endocrinology of male infertility. To begin with, inability to achieve pregnancy after 1 year of regular unprotected sexual intercourse, that's how we define infertility, and WHO has estimated about 60 to 18 million couples worldwide are currently suffering from infertility. What is the scenario in India? Scenario in India is not pretty different from what is worldwide. So, but the percentage is different for different states in the country. So, it's about 3.7% in UP, HP and Maharashtra, 5 to 6%, little bit more in Andhra Pradesh and other states, and about 15% in Kashmir. So, how do I define male infertility? It refers to a male's inability to result in pregnancy. That's what we call it as male infertility. And the problem with male infertility is that, as you can say, that the complexity is more because they don't seek healthcare issues unless there is an emergency. You all will agree with me that whenever a woman comes to us seeking treatment for fertility, usually she is accompanied by her mother or she is accompanied by her mother-in-law, but never by a husband. We have to convince her a couple of times before actually the husband comes and sees us. So, if you see, about 37% of the fertility cases in Asia are because of male factor. And this was a very interesting study, which was a retrospective study published in 2015, and it was a retrospective study done on a data spread over the 10 years and 3084 cases, and you can see a whopping 64.2% of males had abnormal semen analysis report. From that you can know what is the how important is the male factor when we are treating with a infertility couple. I am going to go quickly through the organs of reproductive and then the sperm morphology, and then we will actually start with the endocrinopathies. So, as we all know, the organs of reproduction can be divided into external organs and internal organs. External are the penis, scrotum, testes and epididymis, while the internal organs are the vas deferens, seminal vesicles, prostate and urethra. When it comes to the testicular function, there are two important functions which the testes do. One is the spermatogenesis through the germ cells and the testosterone synthesis through the Leydig cells. If you see the cut section of the testes or the anatomy, it is made of seminiferous tubules where the actual spermatogenesis takes place, supported by the tunica albuginea, the retitestes and the epididymis, where the sperms are stored. Okay, thank you. Where the sperms are where the sperms are stored, and then these are the sperms from the epididymis which are seen in the ejaculate. If you take a cut section of the seminiferous tubules, there are germ cells which are supported by the Sertoli cells, and the germ cells are the ones which are converted into sperms. How much time does it take for a sperm to develop? It takes about 70 days for the sperm production, and an adult male produces about 70 to 100 million of sperms per day. Well, when these sperms are produced in the seminiferous tubules, they are stored in the epididymis. So, is epididymis only a storage organ, or does it do something to the sperm as well? Yes, it does have a very important role to play in the maturation of the sperm. The maturation takes place in the epididymis. It gives it the capacity to for progressive motility. It gives it the ability to attach to the female eggs and penetrate the outer covering of eggs. So, for fertilization, this maturation process which takes place in the epididymis is very important, and from there the transport of the sperm takes place through the vas deferens, where it gets mixed up with the secretions of the seminal vesicles and the prostate, and then the final semen is produced. Let us come to the sperm physiology. The sperm is divided into parts like head with an acrosome cap, a neck, then a middle piece, and the tail. Each one of it has got its own function, but the most important part is the head, which contains the nucleus, which has got the DNA material which is going to get passed to the next generation. This is a very important slide wherein it explains us the endocrinological aspects of male reproduction. We all have studied both female as well as male, but most of our concentration has been on the female HPO axis. There is something called as an HPG axis in males as well, wherein the hypothalamus secretes the GnRH, which acts on the pituitary, which in turn secretes LH and FSH, the gonadotropins. LH acts on the Leydig cells, which is synthesizing the testosterone, while FSH acts on the Sertoli cells and the germ cells, and that is how the spermatogenesis takes place. Now, there is a negative feedback of the testosterone as well as the estrogen, which is produced by the testes, which is acting on the pituitary and the hypothalamus, thus decreasing the secretion of FSH and LH. This is very important when we are going to consider the different endocrinopathies. Another thing which we should know, that sperm is an haploid but to begin with is a diploid which gets converted into a haploid cell by undergoing meiosis 1 and meiotic 2 division. So, when it comes to semen analysis, what all things one should be looking for? In the semen analysis, we should be looking mainly for the count, the sperm morphology, and the sperm motility. So, what should I be considering as normal when it comes to count, motility or morphology? The WHO 2010 manual says that the count should be at least 15 million. The motility should be, previously we used to write down the motility as grade 1, grade 2, grade 3 and grade 4. Now it has been changed. Now we are writing it as only progressive and non-progressive, and 32% at least should be progressively motile sperms. Now, when we have a normal report, it's fine if we have one report with us, but if we have an abnormal semen analysis report, it's said that we have to do it on 2 occasions, and these 2 occasions should be at least 4 weeks apart. We should not label the report as abnormal only based on one report. So, what terminologies are normally used to describe these sperm pathologies? Oligozoospermia, it is a terminology which is used to describe the abnormality of the number. So, whenever the number is less than 15 million, we say that he is having oligozoospermia. Asthenozoospermia is the term which is used to describe the abnormalities in the motility. So, and teratozoospermia is the one which is used to describe abnormalities in the morphology. So, if a person has got all the abnormalities, both in all the count, the motility and the morphology, we say that he is having oligoasthenoteratozoospermia. Another thing what is important is to differentiate between these two terms, azoospermia and aspermia. Azoospermia, when there are no sperms which are found in the semen sample, again on 2 different occasions, 4 weeks apart, we label it as azoospermia. Aspermia, if there is no semen at all, especially if he is having retrograde ejaculation, then we call it as he is having an aspermia. We have considered now what are the endocrinological aspects of male reproduction. We have considered the different abnormalities in the sperm. Let's consider something about the endocrinopathies. When it comes to endocrinopathy, the endocrinopathies are basically divided into two groups, broad groups. One which has got hypo and gonadotrophic, and the other one is hypergonadotrophic. Now they are further subdivided into something called as hypogonadotrophic hypogonadism, hypergonadotrophic hypogonadism, something with androgen excess, estrogen excess, hyperprolactinemia, insulin disorders, and so on. I am going to go into the depth of one by one. Let's start with hypogonadotrophic hypogonadism. Now, it is characterized by low levels of testosterone, gonadotropins, and estradiol. Testosterone and estradiol, both of them are produced by the testes, gonadotropins by the pituitary. Now, HH could be congenital or it could be acquired. When I say congenital, it is the Kallman's syndrome, which is an X-linked recessive disorder responsible for hypogonadotrophic hypogonadism, while acquired ones could be because of trauma, surgery, or tumor in the pituitary. What do I do with these men who are hypogonadotrophic hypogonadism? Pharmacological replacement remains the mainstay in the treatment of men with HH. Gonadotropins and HCG are given to restore the spermatogenesis. What we normally do is we give HCG because it mimics LH. So, LH is going to act on the Leydig cells and produce testosterone. Give HCG, get the testosterone levels normal, stabilize the testosterone levels, and then start with the gonadotropins to bring about the spermatogenesis. A couple of things which we need to remember here is that it may take up to 3 to 6 months for the testosterone levels to get stabilized, after which we can add gonadotropins, and it may take up to 6 to 9 months before we can detect the sperms in the ejaculate. These all things are important when it comes to counseling of the person, because he has to take these injections for that long. So, most of us, what we do normally, if he has to continue with the sperms in the ejaculate, he needs to continue taking the injections. So, most of us freeze the samples once we get the sperms in the ejaculate, and then we ask him to go for an ART. There are some anti-estrogenic drugs which are also used in the treatment of hypo patients, and the logic behind this is that it acts on the estrogen receptors, or it blocks the estrogen receptors in the hypothalamus. The negative feedback from the estrogen is blocked, and that is how the secretion of GnRH from the hypothalamus is increased, increasing the gonadotropin release from the pituitary. Clomiphene citrate is again given in a dose of about 50 milligrams at least 3 times a week. Most of us are practicing once a day tablet, but it has to be at least given thrice a week, and again it takes about 3 to 6 months to get the desired results. Very important when it comes to counseling of the person. What about hypergonadotrophic hypogonadism? Now, it is characterized by low testosterone, low estradiol, but high gonadotropins. It is because of the insufficient or non-existent testicular function. That is the primary disturbance which is found in a male with hypergonadotrophic hypogonadism. What do I do about it? Well, a combination of again pharmacological agents and ART is the mainstay in the treatment. So, gonadotropins, SERMs like clomiphene citrate, aromatase inhibitors like anastrozole or letrozole alone or in combination can be used. Men with Klinefelter syndrome XXY genetic abnormality are found to have hypergonadotrophic hypogonadism. In this, of the two, testosterone or anastrozole is more beneficial to men with Klinefelter syndrome as compared to testosterone. So, there is a difference between the two. One is a steroidal aromatase inhibitor, the other one is a non-steroidal aromatase inhibitor. Optimizing the testosterone levels followed by surgical extraction seems to work best in these men. So, we should not be waiting for a normal sperm count to be there. We should not expect the sperm count to be normal. Even if we get a few sperms, that is good enough for us. Go ahead with the surgical extraction of those sperms. Go ahead, do an ICSI and give him the pregnancy. What do I know? What do I mean by androgen excess? Now, even androgen excess is going to cause abnormalities in the semen parameters, and the reason for that, as I discussed in the first slide when I was discussing the endocrinology, that there is a negative feedback which exists between the ovary and the hypothalamus and the pituitary by the loop of testosterone and estradiol. So, testosterone has a negative feedback. So, any excess testosterone can thus suppress the HPG axis and reduce spermatogenesis. Now, this androgen excess could be because of exogenous supplementation, especially in those who are gym goers and who want to build muscles. They are given these testosterone tablets or injections by the gym instructors. Even the person who is taking it is not aware of what he is taking, so should be avoided to avoid any problems in the sperm parameters in future. And then congenital adrenal hyperplasia is the commonest cause of endogenous overproduction of androgens. What is the treatment for androgen excess? Identify and eliminate the exogenous source. Once you do that, it will take about 3 to 6 months for the spermatogenesis to return to normal. If the spermatogenesis does not get back to normal in 3 to 6 months, then probably gonadotropin therapy or CC may be tried in such cases, but the results are not so encouraging. Similar thing happens whenever there is an estrogen excess in the body. Now, the increased estrogen levels can have a negative feedback on the HPG axis and suppress the spermatogenesis. From where is this estrogen going to come? Majority of this estrogen comes from the peripheral conversion of testosterone to estrogen because of the action of cyproteron P450 enzyme. The ratio of testosterone to estrogen is a crucial indicator for estrogen excess, and therefore, a goal should be to maintain the ratio more than 10:1. So, if you have got 1 estrogen level, the testosterone levels should be at least 10 or more. Any change in this ratio leads to estrogen excess, leading to abnormalities in the sperm parameters. Again, aromatase inhibitors, both steroidal as well as non-steroidal ones, are found to be effective in lowering the estrogen axis. Well, what about hypothyroidism and hyperthyroidism? Does hypo and hyperthyroidism have an impact on the sperm parameters? Yes, they do have an impact on the sperm parameters and should be looked into. So, the total sperm count is decreased if there is an hypothyroidism. The sperm motility also decreases. The sexual function is impaired. The sexual desire is decreased. Erectile dysfunction is seen in men with hypothyroidism. The free testosterone levels are also decreased. LH and FSH levels are also decreased, while E2 levels are also seem to be decreasing in hypothyroidism. More or less same kind of a thing is seen even in hyperthyroidism, except for that there is an increase in the level of FSH and LH, and SHBG is also increased. What do I do in these cases? First of all, we should be diagnosing them of having hypo and hyperthyroidism, and then try to correct it either by supplementing it with thyroid or giving anti-thyroid drugs, and to make the person euthyroid, because after making the person euthyroid, it is seen that it is associated with the improvement of sperm parameters. Another endocrinopathy which is very important for us is hyperprolactinemia. It is associated with male infertility. It could be because of hypothyroidism. In hypothyroidism, there is increased TRH secretion which leads to hyperprolactinemia, or liver illnesses, stress or drugs like phenothiazines and tricyclic antidepressants, or it could be because of pituitary adenomas. Whatever the reason it may be, it is going to have an effect on the sperm parameters. It has got a direct suppressive effect on the hypothalamus, thus decreasing the secretion of GnRH and further gonadotropins. It is associated with decreased sexual desire, erectile dysfunction, and reduced semen quality. What do I do? Well, there are pharmacologic agents which I can use to reduce the prolactin levels and make her euprolactinemic. Like the dopamine agonists, cabergoline or bromocriptine, they are the most commonly and most widely used. Of the two, cabergoline has found to be having higher effectiveness at normalizing the prolactin levels, and I am sure that most of us here are using cabergoline as the first drug of choice when it comes to hyperprolactinemia. What about insulin disorders and diabetes mellitus? Does it have an effect on the male fertility and the sperm parameters? Yes, it does have. It is associated with decreased levels of gonadotropins and testosterone. Again, less testosterone, abnormal spermatogenesis. Diminished count of Sertoli cells, Leydig cells and the germ cells are seen in men who are diabetic and have insulin disorders. There is change in the morphology of epididymis and reduced spermatogenesis. So again, if you are having, if he is having diabetes mellitus, maintaining the sugars, maintaining the HbA1c below a particular level is important to have normal spermatogenesis. What about obesity and endocrine dysfunction? There is increased white adipose tissue whenever we have an obese person. So, increased white adipose tissue, increase in the size of the adipocytes associated with the lower levels of testosterone and again higher levels of circulating estrogens. So, low testosterone, abnormal spermatogenesis, high estrogen, negative feedback, again low gonadotropins and abnormal spermatogenesis. There is an increased peripheral conversion of testosterone to estrogen because more the white adipose tissue, more the testosterone, more the conversion because of the high activity of B cytochrome reductase enzyme. Obesity also leads to decrease in the leptin secretion. Leptin has got a direct influence on the secretion of gonadotropins from the pituitary. That is how even obesity is related to abnormal spermatogenesis. But one thing which is common to all these endocrinopathies is that most of them result in the generation of reactive oxygen species leading to oxidative stress. And oxidative stress is nothing but an imbalance between the production of reactive oxygen species and the scavenging capacity of the available antioxidants, resulting the redox paradox. We all generation of ROS is something which is going on in each and every cell of our body every now and then, but most of the times it is countered by the antioxidant activity, by various antioxidants which are available or present in our body naturally. So, but when I say that reactive oxygen species is the way or it's how the spermatogenesis is affected, but the paradox is that some kind of ROS activity is needed by the sperms, and it is needed for what all things? It is needed for sperm capacitation, acrosome reaction and membrane fusion. So, it has to be a delicate balance between the amount of ROS produced and the antioxidants which are present. Where can oxidative stress strike? It strikes, it brings about sperm DNA fragmentation, then it strikes the sperm mitochondria, again which is a powerhouse of the sperm and the sperm membrane, thus affecting its fertilization capacity. When we accept that oxidative stress is the cause of majority of the male factor abnormalities, then comes the role of antioxidants in the male infertility. As I said, there are endogenous antioxidants, dietary antioxidants and some metal binding proteins which are normally present in our body, which act as antioxidants. But then still, do I need supplementary? Do I need nutritional supplements? Yes, because whenever there is an imbalance, obviously the antioxidants which are produced by my body are unable or are less to counter the reactive oxygen species which is produced, and that is why nutritional supplement from outside is needed, which helps me to improve the sperm parameters like motility, morphology, improves the DNA damage and overall increases the fertility potential of the person. I am quickly going to go through a few antioxidants which are available, and I am going to emphasize on a certain thing. So, L-carnitine and acetyl L-carnitine is a commonest antioxidant which is given. So, it exists in two isomers, but only L-carnitine is active. Now, how does it act? It has a role to play in the sperm maturation during its transit through the epididymis, and it enhances the sperm energy production. It acts on the mitochondria and improves the motility of the sperm. There are many studies which have proven that L-carnitine helps to improve the sperm parameters. Only thing which I want to emphasize here upon, look at the dose 2 gram per day in this study by Lindsay. Garola, again 2 grams per day. Cavallini, again it divided into 3 groups, but L-carnitine 2 grams, acetyl L-carnitine 1 gram. So all the studies which have been published, majority of them have got the dose of 2 grams of L-carnitine. And then now let's go back and see what we are prescribing, how much L-carnitine is there in that tablet which we prescribe. So 2 grams is what is needed if at all we have to give L-carnitine as an antioxidant. What about selenium? It is a part of glutathione peroxidase enzyme that occurs in active form in spermates. Again, it scavenges hydrogen peroxide in human sperms and prevents ROS induced damage. So again, do I have some studies on that? Yes, I do have studies on that. But again, the dose which is needed in most of the studies are 100 micrograms per day. Coenzyme Q, most commonly used, present in almost all the preparations which we have got in the market. It is again a naturally occurring compound found in every cell of the body. It is also known as ubiquinone. And what does it do? What is the role? Its deficiency results into sperm damage. It lowers the sperm motility and sperm count. It is responsible for energy for the movement and all other energy dependent processes in the sperm cell. So, do I have studies? Yes, I do have studies which are published. This was a study which was published in 2020. I am not going to go into the details. Let us jump to the conclusion. What conclusion they draw was, CoQ10 can attenuate ROS effects and enhance sperm functioning owing to its antioxidant activity. Study affirms that supplementation with CoQ10 for the duration of at least 3 months decreases SDF and improves semen quality and seminal antioxidant capacity. Again, what is the dose which is given for CoQ10? It is 100 milligrams, nothing less than 100 milligrams should be given. Another study which shows that there was a mean increase in the motility by 35.7%, while the improvement in the fertilization rate could be seen with the CoQ10 supplementation. A meta-analysis which was published in 2013, they included 3 trials. Again, the results showed that, receiving CoQ10 treatment statistically increased the seminal concentration of CoQ10, the sperm concentration and sperm motility. What about astaxanthin? It's a new kid on the market, but it's beneficial as far as the sperm parameters are concerned. It's a novel carotenoid and it is shown to improve the sperm quality and function. So, what is uniqueness of astaxanthin is that if you see and compare it with other antioxidants, this has got the maximum potency for antioxidancy as compared to lycopene, lutein, beta carotene and all. Now, when I say it is an antioxidant, every compound has got some pro-oxidant activity as well. Astaxanthin is the only one which is a pure antioxidant and not a anti and antioxidant. So, probably it will help or probably it will act better as compared to other antioxidants. Do I have studies? Yes, we do have studies, and the dose which is studied is 16 milligrams per day. Therefore, that is the minimum dose which we should be giving to our patients. There was a 34% improvement in the sperm velocity. There was a 3-fold improvement in the sperm attachment to the oocyte, 75% reduction in the reactive oxygen species with astaxanthin, and 44% increased pregnancy rates were seen with astaxanthin. So, most of the studies have shown that astaxanthin is a promising antioxidant which has come lately in the market. Lastly, melatonin, it has a potent free radical scavenging activity with subsequent antioxidant and anti-apoptotic functions. Whenever the melatonin levels are high, the levels of advanced oxidation protein products, we call it as shortly AOPP, are less, and that is how melatonin helps in improving the fertility of men. Are there studies? Yes, there are studies which have shown that melatonin therapy adds extra benefit to varicocelectomy in terms of sperm parameters, peripheral blood inhibin, and total antioxidant capacity. There are quite a few studies which are published again in favor of melatonin as an antioxidant. Commonly used folic acid, zinc, they also have antioxidant activity and can be used or can be given as supplements along with other antioxidants which we have just described. So friends, to conclude, endocrine regulation of male reproductive system is an intricate process. It involves many positive and negative feedbacks and modulations. So quantitative and qualitative defects in this crosstalk can lead to spectrum of endocrinopathies such as hypogonadotropic hypogonadism, hypergonadotrophic hypogonadism, androgen excess, estrogen excess, hyperprolactinemias, insulin disorders, and so on. Precise understanding of these endocrine disruptions will help us treat them in a better way. And at the end, I would say that let's start concentrating on the male partner equally as we are concentrating on the female partner when it comes to investigating a couple for fertility. Thank you so much for your patient hearing. I would request all of you to support the candidature of Dr. Sunita Tandulwadkar for the Foxy Presidentship. Election year 2023 and the presidential year for her would be 2025. I would also like to take this opportunity to welcome you all for this event which we are going to have on 30th and 31st of July, National Conference on Reproductive Endocrinology. It is going to be, the scientific partners are going to be the Endocrine Society, Endocrine Committee of Foxy, and the Gynecological Endocrinology Society of India, that's JC. So I welcome you all for this event which is going to be there on 30th and 31st of July at Hotel Hyatt Regency, Pune. Thank you so much once again.
Thank you, Chaitanya. The last sentence on the last slide, that precise understanding and insight of the endocrinology is most important in treating the male infertility. So it was a very detailed coverage of all the treatment modalities. Thank you so much.
Thank you, sir.
Dr. Doshi sir and Jamma ma'am, please to felicitate Dr. Ganapule sir.
Thank you. असं धरू का? Thank you.
Hello, I would now like to ask Dr. Jamma Madam to please felicitate Bahubali sir.
Total overview of my infertility. प्रत्येक hormone wise घेतलं ना, that was quite.
Heartfelt thanks and gratitude to our respectable speakers, Dr. Sunita ma'am, Dr. Chaintanya Ganapule, Dr. Girish Kumthekar. My sincere thanks to all chairpersons, all members of society to attend the CME in large number. I thank MCure, our pharma partner, for the beautiful evening. I request everyone please join for the dinner.